Today, I want to dig into something that is honestly really important and long overdue. Why is there such a gap in the way that doctors understand and treat female hormonal health? This isn't just an academic issue, it's very real. If you're a woman who has ever felt dismissed by a doctor, told that it's normal and it's just something that happens as we get older, or frankly told you just need to lower your stress, you need to get more sleep, or just given birth control without any kind of real explanation as to why you're using it, you're not alone. This happens all the time with clients, with family, with friends, and it's happened to myself. So today I'm going to break down why this gap exists and what you can do about it. For most of medical history, women are largely left out of clinical research. Now, this happens for several reasons. First, there is a big risk of pregnancy. Both drug companies and researchers are afraid of causing any harm to a fetus, so they just excluded women entirely. Second, female hormones, they're very complex. They fluctuate, and they don't fluctuate on a standardized cycle. They're often seen as too complicated and volatile. Because researchers wanted a simple model, men became the default standard. Now, this had huge ripple effects. Because drugs were tested on men, recommended dosages and side effects, as well as risk factors, didn't always apply to women. Even when you look at symptoms of a heart attack, although it's taught as chest pain, oftentimes women present differently. And even today, most animal studies often use male mice. We see this directly reflected in the way that women are prescribed TRT. Oftentimes, the dose is much too aggressive, and risk of virilization is something that very rarely is covered. Number two, medical training and textbooks. Medical training and schooling is built upon the current research that exists. If women weren't included in these studies, then medical schools, instructors, they don't teach future medical professionals how to recognize specific symptoms, often nuanced, complex, and chronic, when you're experiencing female-specific hormonal issues. Having been through nursing school, I can tell you that there was one lecture where we covered the menstrual cycle. It wasn't overly specific, it wasn't comprehensive, and it was pretty surface level. Now, hormonal disorders, they're often taught as rare or as textbook cases, not the real life, messy, overlapping symptoms that a lot of us, myself included, have experienced. This is why when you show up to your primary care or even your OBGYN with fatigue, emotional volatility, lower libido, they might not know how to connect the dots. And this just simply comes down to the fact they were never taught how to. Let me give you a more recent example. I was working with someone who has been on hormonal birth control her entire life. She told her doctor that her and her husband were looking to start having kids, or at least trying, so the recommendation was to come off the combination pill. Once she did, she started experiencing a lot of unwanted symptoms: fatigue, anxiety, pain, just general lethargy, and her doctor prescribed Lexapro. She also told her doctor that she was having trouble losing weight, and it seemed like it was due to coming off the hormonal birth control. So they prescribed a GLP-1. She told her doctor that she was always hungry, and even if she ate comfort foods, she didn't really have a cap on how much she could eat, and it always left her feeling crappy afterwards. She also reported that lately she noticed an increase in acne, and it was really hard to manage her skin. Without checking labs, her doctor diagnosed her as PCOS. They told her that the GLP-1 would help her lose weight. They also put her on T4, T3, even though her TSH was only 1.5. They never looked at her circulating androgens, including DHEA, testosterone, free test, and DHT. And in her last visit, they said that maybe she should put pause on trying to conceive and get back on hormonal birth control until these symptoms resolved. Nonetheless, I gave her my best piece of advice, which was find a new doctor. This feedback loop means that undertrained, undereducated doctors are oftentimes mistreating, misassessing, and misdiagnosing patients. I mean, I think many of you guys know that our hormones are pretty complicated. And here's what most people don't realize. The menstrual cycle isn't just about periods. Every week, our hormones are shifting. Now, this has a direct effect on mood, energy, pain, libido, and symptoms can often overlap with other problems. Anxiety and depression can spike right before your period, but so can fatigue, gut issues, and joint pain. And even if your values are technically within range, a mismatch or a lack of balance in the ratio of estrogen to progesterone can cause these same symptoms to manifest. Now, doctors are trained to look for patterns, yet female hormones are often messy, and it's very rare that they fit into this neatly packed, organized, and consistent box. You might have migraines, mood swings, lethargy, lower, decreased libido, and you could very well see several specialists, none of which connect it to a hormonal imbalance. And even lab tests can be tricky because the truth is, the reference ranges that we see next to a lab value can sometimes encompass undiagnosed, comorbid individuals, meaning women just like yourself who are experiencing imbalances. Timing is everything, and timing specific labs will result in those values having different meanings. I can't tell you how many times I've had someone come to me who is on TRT, and their doctor has recommended that we assess only the trough, the lowest point in which we're capturing where their serum testosterone levels are going, because frankly, they just want to make sure that the patient is not symptomatic. Yet, they don't really have a good grasp on the high point, on the peak in where those levels are reaching after injection or after administration. It's even more common to have individuals come to me who requested labs from their doctor, and as I'm combing through, I'm seeing values that are pretty concerning. Estradiol is in the tank. There's no sign of progesterone. And when I inquire, when were these labs drawn? What day of your period? What day of your menstrual cycle? And they come back with, I don't know. My doctor said it didn't matter. Listen, this isn't a video to shit on doctors or the medical community. This complexity is really hard for patients to understand, and it can be very hard for doctors who, frankly, never received this kind of training. But that's not an excuse. Now, this is where things get uncomfortable. Number 4, bias and dismissal. There is a bias in medicine based on age, based on appearance, based on whether or not you've had consistency in your cycle or you've previously been able to have kids. Some of it's conscious, but much of it's not. Historically, women's complaints of fatigue, emotional volatility, PMS, pain, anxiety were dismissed and said to be psychological and even hysteria. Even now, when you look at the insertion of an IUD, women are oftentimes given very poor or completely denied pain management strategies. A woman with endometritis can be dismissed very easily and told for years that these symptoms of pain are just the cost of having a period, and all of us experience it. Women with PCOS are often told, lose weight, take better care of your skin, or here, let's just start birth control, even though pregnancy is not a concern. This kind of relationship, it erodes trust, to say the least. It's very discouraging. It makes women less likely to seek care. It makes them less likely to report and consistently keep track of symptoms and changes. It also discourages women to speak up when something is wrong. And it also means real issues, real conditions often go missed and untreated. Not to mention the fact that then you have undiagnosed system disorders making up the sample size and the reference range for current lab work for other women. If you've ever been told this is normal and it's something we all go through and it's something that you can expect with age, yet your gut is telling you that something is seriously wrong, this is where I can't recommend enough to be strong, be courageous, advocate for yourself. And even if that means seeking a different provider, someone who is a little more trained and a little more modern with the times and just frankly more empathetic. It is a pain in the ass, and it does take a lot of work on your part. Now, the bias isn't just about individual doctors. It's not about the public health sector. It's not about who your insurance will cover. This is systemic and can also be something that people run into even when you go private. even when you go to a concierge doctor, a wellness clinic. The sad thing is that in many cases, when you go to a wellness clinic or an HRT clinic, you aren't as informed as far as the education and the qualifications that the person who you're meeting with regularly and who's making decisions around your hormonal health actually has. This is why you especially have to be on guard in the case that you were given an anabolic like TRT or Anavar or any synthetic anabolic, even DHEA. There are established reference ranges that we have proven and outlined in clinical research to the degree in which masculinization is likely to occur. Women do not respond to anabolics the same way that men do. We are much more sensitive, and it's something that needs to be handled with care under the right supervision. Now, number 5, continuing education. Medicine changes fast, and the system, frankly, isn't set up for doctors to stay up to date, especially when it comes to women's health. Most doctors, they finish medical school and only seek continuing education relative to their specialty. And I'll say firsthand, like with my degree in nursing, when we got to the section around HRT, it was pretty discouraging to hear that across the board, it's something that's not encouraged. There isn't really an option for women to start HRT, and the best recommendation is to get in more micronutrients, lower stress, and get more sleep. Unless you're an endocrinologist or someone who specializes specifically in women's health, you might not ever get trained or retrained on updated guidelines. Even OBGYNs, I've seen some that are truly just so appalling in that they don't understand the difference between a synthetic hormone and a bioidentical one. And again, it's not to say that all doctors are bad or that there aren't professionals out there who will advocate for your well-being and be empathetic. And I'll say firsthand, it is a big pain in the ass to find a provider that is aligned with you in terms of values, what you're comfortable with, and can really help guide you. But I was fortunate after maybe about 6 OBs, finding one that really understood my needs and understood that when it comes to birth control, there is a serious consequence with putting someone on synthetic hormones. Now, number 6, systemic and structural barriers. Listen, the healthcare system is built for acute and obvious problems: heart attacks, infections, broken bones. Female hormones are usually chronic, slow to develop, complex, intermittent, often invisible, and typically have some degree of overlapping symptoms. Fact is, there are barriers with insurance too. And some doctors find that their hands are tied in terms of what tests they can get run, what is going to be something that insurance will allow for. And the fact is, funding for hormonal research, both in men and women, lags way behind other disease processes, including heart disease and cancer. So what does this mean if you're a patient? It means that even with the best intentions, even with a very suitable, well-meaning doctor, they might be underinformed, undertrained, or unfamiliar. And it might mean that you really have to do a diligent job advocating for yourself and asking for more. And here are some things I would just say, generally, most people don't know, and it really pays to be informed about this. Synthetic hormones do not operate the same way that bioidentical ones do. Synthetic hormones are what's used in combination pills as well as the hormonal IUDs. Even though doctors will kind of peddle hormonal IUDs as a much safer alternative to copper IUDs, you have to know that with synthetic hormones, these effects are not just local. They are systemic. The thing that birth control, specifically hormonal birth control, is really good at is preventing pregnancy. And it is oftentimes the case where doctors don't walk you through the cost that you're paying for that pregnancy prevention. Hormonal birth control is going to suppress ovulation. That is the fundamental mechanism in which it works. It's also going to affect metabolism. It's also going to affect micronutrient uptake. And in the essence of trying to preserve fertility, the thing that is the most harmful for someone who would like to have kids or would like to have the possibility of having kids down the road is sustaining a state of infertility, which is exactly how hormonal birth control works. Timing your labs in accordance with your menstrual cycle at a specific point is critical. It's not good enough to check to see if you got your period this month and say, well, I get it about the same time every month. it pays to know the exact days. And this is why I recommend just understanding that day 1 of your period, that is day 1 of your menstrual cycle. The typical length is anywhere from 28 to 32 days. Just because you get a bleed does not mean that you're ovulating. You need a specific ratio of estrogen to progesterone, and even more specifically, a type of estrogen, estradiol. If that ratio is out of balance, even though technically your estradiol might be within the reference range, you could be symptomatic and more specifically experiencing symptoms of emotional volatility, water retention, bloating, heightened anxiety. Now, this doesn't mean to get on an estrogen blocker. It doesn't mean to start taking DIM or Nolvadex. It means that we need to get to the root cause as to why your progesterone is imbalanced. We also need to confirm if it's rising. And this could very well be resolved or understood better by timing labs appropriately. Listen, the discrepancy here, it's not your fault. You didn't cause this gap, but you can be informed and you can be proactive. And if your OB, your primary care, if they are just peddling out hormonal birth control and almost upselling the benefit as you won't get a period eventually, this is a huge red flag. Learn how your cycle works, ask questions, advocate for yourself, and lastly, don't be afraid to get a second or third opinion. And more importantly, share your story. This is a very vulnerable thing that so many women experience. The more we talk about these issues, the more pressure there is for the system to improve. If you found this helpful, share it with someone who might also benefit from it. As always, thank you guys for watching, and I will see you in the next one.